Hello, everybody. My name's Paul. I'm an old age psychiatrist right in the north, up in Bedford. I'm quite new to the trust. Well, I came just pre-pandemic, so I have never really been down here before. And in fact, I've never seen so many faces for like 3 years. So I apologise if I'm a bit nervous or a bit clunky. I have a bit of an interest in ethics. I did an LLM in my training, did a bit of work with the college around the mental health act stuff when I was in my training. And then I'm a member of the Luton and Dunstable Ethics Committee, which is a general hospital ethics committee, which I think is quite interesting, the difference between that and the current ethics committee, or the one that was set up in ELFT. So that's really my reason for talking here. And this one is to kind of put the basis of why an ethics committee might exist in general, why it might exist in a mental health context, and yeah, around about that. My slides are pretty boring, but half of them serve as an aid memoir to me, so I make an apology for that straight off. So, first of all, the plan of this is just to talk about ethics in clinical practice in general, and maybe get you thinking about how you and your teams embrace ethics when you're thinking about clinical practice. So that's what I want you to have in your head while you're thinking and listening to me. How ethics committees have been seen in the past and some of the controversies around ethics committees. And then how they changed a bit in the pandemic and this potential new role that they had. And then talk a little bit about the ELFT Ethics Committee. Stick your hand up and ask any questions if you want as I go along. I think the main part of discussion is going to be in Richard's talk later, but I'll leave a bit of time for discussion at the end. Okay, so the context, pretty simple. My understanding is ELFT's not had an ethics committee. People who've been here longer than me, which is probably most of you, might correct me on that, but ELFT's not had an ethics committee. And then the pandemic happened and many places that didn't have ethics committees set up an ethics committee, ELFT being one of them. And the ELFT Ethics Committee closed itself down about 4 months ago. I guess it's still there in theory, but it isn't meeting anymore. And I think that's the context of why this might be interesting. So I think this is probably the only psychiatry ethics book I've looked at. I wouldn't say read, but I've looked through. And the first chapter and the first page in this in the introduction, so this was first done in 1981. And then the third edition was in, I think, 1991. And then the fourth edition was 2001, I want to say. And at that point, they said, we no longer need the question, why a book on psychiatric ethics? Because it's found a secure place in both clinical and research practice. I don't know what you think about that. Is it a secure place in your and people who you work with clinical practice? I was a bit unsure about that, whether it was a secure place, but actually reading how that sort of paragraph finishes, a growing commitment to accountability on part of mental health professions, coupled with an informed consumer movement. And I think compared to 1981 to sort of mid-2000s, there probably is quite a shift there that's happened. The consumer movement, as it's called, definitely has more of a place than it would have 30, 40 years ago. And accountability, when we think about investigations, whether we think about clinical governance, I would say probably has increased significantly in that time frame. I'm not sure that's controversial. Whether it's to be where we want it to be, that probably is a different question. So, does ethics have a secure place in your clinical practice and what you're thinking about? And when I say yours, obviously everyone views themselves as ethical and they think through everything, but just imagine how your teams are working and the discussions that you're having within teams. I think loosely, ethics is a framework of moral principles applied to clinical decisions. So frameworks of core principles, core moral principles being applied to clinical decisions. And we've got a few of those. I'm no expert ethicist, but if you think about the trust values that we have, we care, we respect, we're inclusive, and that we make decisions with those virtues in mind. Now, I think if you are doing that policy and you've got those thoughts in mind when you're making all of your clinical decisions, discharges, admissions, all that kind of stuff, potentially there's an element of something called virtue ethics in that there's these virtues that you have and you're using them in each of those principles. That's a recognized ethical framework. Think about good medical practice. Another thing that maybe doctors always have in their mind whenever they're thinking about making decisions. That's very much duty-based, duties of a doctor, so a deontological ethical framework. I'm stretching it a little bit more here, but if we think about things like doing things in someone's best interest, the Mental Capacity Act, not really, it's the outcome that we're worried about. When we're thinking about, we can do all these decisions, but where do we end up with these decisions? And you can think of that as a consequentialist ethical framework. So I think things that we don't think of as ethical frameworks, we are quite aware of. They influence our practice, they're going on. I guess my question to you is thinking about times when you feel like ethics isn't really thought through. And this might leach slightly into Chloe's talk next, but I think there's a bingo game in your bit next. But this is my contribution to that bingo game. The things that you see in the notes, now none of you will write these, but these blanket statements that seem to justify decisions. I've seen these. I'm not saying that they're everywhere out there, but I'm not saying that there isn't such a thing as a threshold to services or a criteria that services should have, or that there's detainability criteria out there. But when you see these bold statements that seem to justify a decision without any weighing up of the thinking behind them, to me, these aren't ethical thinking. This is using terminology to avoid ethical dilemmas, which are horrible and painful to think about, but are out there. So I mean, I won't ask you to put your hands up, but I suspect most of you have seen language like this used in it. And I think that suggests that people aren't embracing a framework of thinking about ethical dilemmas. Plus, it could be 2 in the morning, and your ethical thinking at 2 in the morning is sometimes a bit different. I'm not going to talk too much about capacity because that's going to be Chloe talking about next, but I think when Chloe is speaking, the way it links in now is how we ethically, what ethical frameworks are we using when we're using some of these capacity terms and making decisions based on capacity? What ethical dilemmas are going on in our head or within MDTs? And my little plug, I'm one of the clinical leads with Juliet for climate action in the trust, is I would say the moral duty of individual healthcare professionals and organisations to act on the climate emergency and the costs we're doing out there is one of the great moral issues of our age. And that is not something we really embrace in our ethical thinking, I don't think. I don't think we have those discussions in MDTs about, well, we could do this thing and it will meet these ethical principles, but what about the carbon footprint? How individuals link in with the organisation, how people are activists or not activists, those kind of issues, I don't think we really embrace. And given I view this as like the moral debates of our generation, I think that's a bit unusual. But that's my little plug for that, and I will move on. So there's ethics, and then there's ethics committees. And how do those two things interact with each other? And this is from a Journal of Medical Ethics, a discussion about the place of ethics committees. And this is saying that in order to rationally think about moral and legal principles, it must be grounded in collective discussion. That's the core of how you're testing these principles out. It's collective discussion. And if you think about some of the decisions that are made around patient care, clinical pathways and things, having a think about what that collective discussion entails is interesting. And this goes on to say, sorry, the slide merges a little bit there at the bottom, in the face of a moral and legal indeterminacy, a posh way of saying uncertainty, such decisions confirm with procedural principles, participation of those with relevant expertise, effective, fair debate between them. So you're having a collective discussion of people with the right skills to have that discussion, and it's a fair discussion where everyone can make their point of view and it's structured. That's the key. And this would suggest this is the way to get to the heart of an ethical issue. So have a think about the times when ethical decisions have been talked about and whether you feel they've been in this collective discussion way and in this structured, fair, well-resourced, expertise-driven way. And I think this is what we're suggesting that an ethics committee brings that maybe other forums don't bring in the same way. So ethicsy, I don't think it's a word, committees in ELF. I know up in Bedfordshire, we've got a complex case capacity forum. There are sometimes complex case committees around there. And then you've got various management committees, quality committees, DMTs, or MDTs within the team. You've got various different forums. I guess I wonder is how those forums allow collective discussion with expertise and fair debate between everyone there. And I'm not sure all of those forums have the expertise and have the ability to have structured fair debates between them to come to an outcome that we would think of as an ethics committee would do. So have a think about that when we're talking, in particular with Chloe's thing, about how these issues are talked about in committees and organisations. So, ethics committees prior to the pandemic. There were ethics committees for a long time. I mean, I probably should have looked up when the first ethics committee was found or something like that to start this slide off. But a few of you, many of you, some of you may have listened to Radio 4, so we've got Inside the Ethics Committee, which is a very interesting programme. I think it's mostly the St George's Ethics Committee in southwest London. And I know the local mental health trust there sometimes uses that committee as its way of doing it. If anyone at the back wants to come and sit at the front, there's loads of spaces around at the front, save you standing and sweating in the heat at the top. So Inside the Ethics Committee, and if you look on the most recent talks in the Inside the Ethics Committee, there is some quite mental healthy-like stuff in there. So I think this is the last couple of series of it, and on series 12 now, I want to say, treating patients with dementia and suicide. Two really core issues. So this isn't a mental health ethics committee, but they're talking about these kind of key issues. So there are 85 ethics committees in the UK, that's according to this clinical ethics network. And then there was this paper, a systematic review of it just before the pandemic. I know there's a lot of words on there, but essentially the top paragraph said that in this review that they found recurring themes that actually ethics committees helped with healthcare profession satisfaction. So healthcare professionals had high satisfaction rates with the ethics committee. And it was correlated with having lower moral distress among staff members. Maybe hold that in your head when we're talking about the role of ethics committees when it comes to the end and the discussion later. But it seems to have some real powerful effect on the people who make the referrals in. And something around moral injury and moral distress. What it isn't clear about is how it informs clinical decisions and how it helps patients or service users, what their satisfaction is. There's very little looking at that with ethics committees. And that is one of the recurring criticisms of ethics committees about where's the patient voice, where's the service user voice in them. This sort of culminated, again, just before the pandemic, there was a bit of controversy. It definitely went round ethics committees that they needed to think carefully about this. Following there was a case that a judge made some really quite critical comments around Great Ormond Street Hospital's ethics committee, is my understanding. I don't know the case too well. But essentially saying that the lack of parent involvement in that ethics committee, the lack of service user involvement, if you want to frame it more broadly, in ethics committees, just seemed wrong. And that the ethics committee should be thinking about how it gets that involvement in earlier. And we're going to come on to in a second about how ethics committees get their information. So a real criticism, and it was quite stinging criticism about how the Great Ormond Street Ethics Committee worked, but I have a feeling that would apply equally to most ethics committees around that time. And then this is Daniel Sokol, an ethicist. I think he's a barrister by background, who's written quite critically of ethics committee. I'd say he's going to sound quite critical, and I think he was. He presses this by saying he's sat on 2 ethics committees and he has nothing but admiration from the people who sit there and the thoughts that they put into it. But I think it's more the process that he had some criticisms about. So composed of mostly people by the NHS Trust, very few non-clinical members, though there are some, but often they're the minority in there. And I would think probably when you're in a room full of doctors talking about medical things, that's quite a hard voice to make if you're in the minority, the non-medical voice in there. And most people are employed by the trust. They may be non-exec people who are going to give a different view on things, but they're all to do with the trust. It's pretty trust-based. All the information often comes from the clinician, because essentially how most ethics committees work is a clinician will come and say, I've got this ethical dilemma. They will provide all the information. They will provide what the patient's view is about it, what the family's view is about it. And they will provide all of this information. So it's all coming from the clinician themselves, which probably gives a certain spin on the information that you're getting in an ethics committee. And I would agree with this when I've seen it previously in different forums of ethics committees, that you have very little access to the fact. Often, what you're presented with is on the day facts, and often you're asking questions that there aren't answers to in that committee. So you're saying, well, what was the family's view on this? I don't know. And then you're trying to make a decision based on stuff where you haven't got the full information, or you haven't had the time to carefully consider the information. And often, Daniel Sokol wrote that there's often not experts in that medical specialty in question. So some of the nuanced information you might want to make the decision or to advise on things isn't there. And what he suggested was that you should pay people. It's often the outcome of these kind of criticisms, that you should have a paid person to do a job, and that they should be paid and trained in ethical decision making. That there should be more representation at that meeting. And I guess not surprisingly, coming from a barrister, that potentially it takes more of an adversarial way, where there will be two different sides presenting the information to the ethics committee, potentially maybe the parents of the child presenting their views, and then the doctor presenting their views, as having more of an adversarial way. And I guess that the theory around this is the theory of natural justice, where you've got two opposing positions debating against each other. And when this came through ethics committees, often the response was, we're not really a decision-making committee. We are there to help clinicians understand the ethical principles that they will be making a decision on. So we don't see ourselves as the decision maker around whether this person gets the treatment, whether this person goes to ITU, all those kind of complex decisions. We're not the decision maker. We're there to make sure that the clinician has considered all the ethical things, and it's up to the clinician about what the answer is. That's kind of the rebuttal to that argument that there needs to be more adversarial, more open ethical framework. It's really an ethical advice to a clinician, which jumps back to how they're perceived as being quite useful in helping with moral distress for the clinicians involved. My experience with other ethics committees, very briefly, I also sat on the Bedfordshire Hospitals Ethics Committee, which I'm actually missing today because of this. It's very case-based, so it's very much the gastroenterologist coming, I've got this patient and these are our options, what should I do? Very much like that, rather than some kind of overarching policy review. It's quite reactive, so we're not going out searching for ethical quandaries on all the dark corners of the wards, and we're waiting for people to come to us with a specific question. Lots of referrals, wow, 1 or 2 every month. Lots compared to what we got in ELFT. So clearly, I think that suggests that people get benefit from it and people find it useful. Well, at least the referrers who are making these referrals find it useful. A real large amount around capacity and best interests decisions. And if we broaden mental health component to mean impaired decision-making ability, I would say around about 80% of the referrals that are coming to the general hospital one have a mental health component to it. And I suspect most of you sitting in here who've got a mental health background or have, well, yeah, mental health background would think some of it is quite routine best interest decision-making stuff. I think we would think, well, that's just a best interest decision someone's got to make. And you've got to get the right people around the table and make a decision. That's my view of it. But then I'm biased by the fact that I come from a mental health trust where that's commonplace. And I wonder whether some of the ethical quandaries that we deal with and we think are quite simple, we just think are simple, but maybe we should be thinking a bit more about them. But we just think, oh, they're a routine, it's just a best interest decision. Because other professions seem to think these are really morally complex issues. So my first reaction was to think, oh, they haven't really read the Code of Practice for the Mental Capacity Act. Maybe they've understood it a bit better and realised the complexity of what they're doing than I have. But take-home messages, lots of referrals, and lots around mental health components. Then the pandemic hit, and this is from the NHS providers, and they noted that suddenly there were more clinical ethics committees. And if Frank was here, I think there was a message that went round that most trusts should have an ethics committee. There was a central message that went round saying, if you haven't got one, you should be setting one up. And pandemic's coming, there's going to be some difficult decisions. So the NHS providers, they noted an increase in that, and they were suggesting that the board ethics committee should, this is quite different from a reactive, here's a case with this patient, what decisions should I make with this individual patient? They were suggesting this, to check that there were policies in place, to check there are systems and processes in place, and to check that those systems and processes are fully understood by all those that use them. That's quite, I mean, the ethics committee that I sat on in Bedfordshire Hospital isn't set up to do that. And I suspect not many ethics committees are set up to have that kind of oversight of policy across the trust and implementation. And here's where I think ethics committees were pushed a little bit, so that they will need to consider and identify principles of an ethical approach to prioritising treatment in worst case scenarios. Now, you've got to remember, I'm sure you all do, that spring of, I can't even remember what year it was now, 2 or 3 years, when the pandemic was hitting and we just didn't know what was going to happen, and there was all sorts of worries about ITU being overwhelmed and things like that. And ethics committees were pushed into thinking around about policies, and trusts were pushed into it. But at the same time, I don't think there was any government action to maybe suggest that the Mental Capacity Act should be halted for a while to change the decision-making principles that we should be using. I don't think there was any government action suggesting that there was going to be rationing of services. So I think there was a lot of push on local trusts to come up with rationing ideas. And then definitely when a few did, they hit the press and were criticised very quickly. I can't remember, somewhere in the West Country, a group of clinicians put together a potential talking, discussing point thing about rationing, about escalation pathways, and that didn't go down well in the general press. And yeah, I think people backed away very quickly from doing that individually on the trust level. And then also providing support. There was lots of talk of this three wise people, idea about that it should always be 3 people on call when there's a difficult ethical quandary, essentially ventilators, not enough ventilators, who should get them overnight. So should be 3 people available, and ethics teams should be able to support them in that. This is essentially saying that there was a survey of all the ethics committees in the pandemic, and it doesn't fit very well with the numbers because you look at the clinical ethics network and there was more ethics committees there. There were some ethics committees in the clinical ethics network that didn't respond to this survey, and there were some people who did respond to the survey that weren't in it. So it's not a great survey in finding all the ethics committees, but around about over half of them started making local documentation. And about 2/3 of that half, I can't do my fractions, but 18 of the 45 were involved in making policy pathway decisions in hospitals. So they were moving beyond that reactive, we've got an individual case to you, to going on to making more policy decisions around that. So that brings us on to the ELFT Ethics Committee. And this is from our terms of reference. I think the bottom 2 there never quite got implemented, the service user and the layperson. And some of those, so the frontline medical was Richard and me, so some of those have got 2 people in there, but loosely this is the makeup of it. Yeah, so that was the ethics committee that was set up. And then this was broadly the framework that we were using in some of those discussions. So the wording's a bit small there, but it's the ethical framework we were using, looking at sort of those 8 big areas about the principles that we should be considering in the decision making. And I think 8's a lot to keep in your head if you're trying to weigh up a decision. So there's a criticism of that. I feel it is far better for some of those decisions than the ones that probably we all remember from medical school, which is the Beauchamp and Childress, the 4 ethics principles. I think I want to say autonomy, beneficence, non-maleficence, and justice. I think it's better for these broader decision-making ones. I think those 4 ethical principles are quite good for, you've got a service user in front of you and there are 2 or 3 treatment options for that one person. So you're thinking, which of these principles am I going to use? When you're weighing up things like a right for staff to refuse a vaccination versus the right of a patient, talking about autonomy doesn't really help you because there's lots of autonomy going on there. There's autonomy of everyone involved in that decision. So I think this is a broader ethical framework that fits better some of these more complex decisions. And then this was the ethox approach that was used. There's quite a few words on there, but loosely what you're looking at is trying to identify the options. So you're writing down the options. Under each of the options, you're putting the moral arguments. You're picking an option which you think is best, and you're essentially trying to rebut it. So you say, this is what we're going to go for. Can anyone make a good rebuttal to this argument, to this option? And if you can provide a rebuttal, then you need to think of other options. If you can't provide a rebuttal, then potentially you need to go ahead, make a decision and review its outcome. That's the approach. And that was the framework that we used. So the progress of this, monthly meeting for 2 years, and there were referrals, 5 referrals I remember discussing. I'm looking at Richard, that's about right. And I want to say 3 of those came from people within the ethics committee. It was almost like we were trying to think of cases that we wanted to discuss to keep our ethical muscles flexed, if that's not a mixed something. COVID positive people going into physical health rehabilitation and the effect that might have and whether to exclude them. Some non-COVID ones, the one I brought was someone who was declining to go to London from Bedfordshire, where the only bed was available. And late on, the vaccine policy got discussed around staff vaccine policy. Although I think decisions have been made and discussions had, and it was for us to reflect on those discussions that had already been had. So coming to the end of my little bit there, and I've got a bit of time for a few questions, but I guess my thoughts at the moment are about how ethical principles are discussed in your meetings. And so in your MDTs, when you're choosing to accept a referral or not, bed management, when we're thinking about whether children should be admitted or not, those kind of decisions. Are ethical principles, are moral frameworks being used in those decisions? I mean, I don't expect an hour-long ethics committee for every admission to hospital, but how are those kind of ethical frameworks, how are they discussed? Ethics committees are, I think, slightly controversial because of the stuff that I said before, and how they fit in within an organisation which has governance frameworks. I suspect the management in an organisation will be quite nervous of a group of high-minded ethicists speculating about their policies, going, well, have you considered this, this, and this? I suspect that would be quite, I'm not sure how welcome that would be. And how useful both service users and clinicians might find the format of an ethics committee. And while we're going to talk in the last bit about why it didn't work out very well in ELFT. And so I think we're going to be asking you, because essentially my not controversial suggestion is it didn't work very well in ELFT. We didn't get many referrals. No one seemed to really want us to discuss their cases. And I guess the question is why is that? When I also suggest that I think we're dealing with some horribly complex ethical issues, and some of the things that we come across suggest these ethical considerations aren't really being weighed up. And my theory is that the reason the gastroenterologist likes to go to the ethics committee potentially is not to get all the ethical considerations there, but it's to help their moral injury, it's to help the moral harm that they're facing by a really complex decision. And we have other ways of doing that. And I suspect relying on legal terminology is one way that we avoid moral injury. Having MDTs, which we have a lot more of than in physical health, We have a lot more MDTs. So we can say MDT decided at the bottom of our entry. And who can argue with an MDT deciding it? Having been in some MDTs, it's not really a whole big hour-long discussion about the pros and cons of it. It's someone saying, this is what we should do. Does anyone have any objections? No. Okay, all your names are attached to it. But no, there are better MDTs. I suspect that you've seen some MDTs work like that in your time in different places. So I think we have got ways of avoiding moral injury that may be maladaptive, I suspect. But that's why we don't feel the need for an ethics committee. When I would argue the moral decisions and the moral harm happening to us is far greater potentially than some of the physical health decisions that go to ethics committees in general hospitals. So I will leave you with that to think about while Chloe talks probably on quite, I think it's reasonably well into that. And then we might have a big discussion at the end about what your views are on that and what your views are on how ethics sits in things. But if you've got 2 minutes, if anyone's got any questions or any objections to what I've said, then stick your hand up. There's a couple, so I might stick to these 2, and then we'll move straight on to Chloe. That's okay. So there was one over there. People. So 3 wise people is a theory. Well, it was put out there that there will be 3 senior healthcare professionals available at any time in the pandemic, often proposed as being the ITU consultant, the medical consultant, and one other person, that they would be able to make a decision about a ventilator bed. Now, the way COVID played out, I'm no expert, I'm no anaesthetist or ITU person, the way COVID played out, the length of time that you would go on a ventilator for meant that there weren't too many of these decisions. There was no rationing of ventilators, there was no rationing of ventilators. So in the end, that kind of idea that you had 6 people in A&E all needing a ventilator and you've got 1 ventilator and you've got to pick which one of those 6 who will all benefit goes to ventilator. That never quite played out in practice. It wasn't overwhelmed through lots of hard work and partly the way that COVID played out, the disease itself. But the idea is you have 3 people who will make that decision. It wouldn't be on 1 clinician to choose who went in. And that goes to moral injury, I think. You do not want to be repeatedly at night making a really big moral, potentially legal decision by yourself overnight. So having 3 people starting that's the principle. I don't think it was talked about as something that could be used. I never came across it. I'm not sure, I never heard of it actually coming into practice. Does that make sense? And then there was one question. Yeah. Join the, yeah, I mean, when I've sat on it, the idea is not to go into legal stuff, because what you should do and what's legally possible are often 2 different things. And I think most ethics committee will be saying that they are trying to make sure that all ethical principles have been used and that it's been viewed from the right way to make that decision. That decision may not be legally possible or not, but that's to do with the hospital legal team. So I think specific legal knowledge in something isn't necessary, although is extremely helpful, because you've got someone saying, you can't do that, you can't do that. If you do that, you need to do this. And that's useful. So some ethics committees have the hospital legal team or someone from there sitting on them. But we're not looking for a legal opinion, we're looking for an ethical opinion. Not to say a judge wouldn't have good knowledge of all the ethical principles, but I think the specific legal stuff, most ethics committees wouldn't see that's their job. Does that make sense? Okay, well, I might end there and hand over to Chloe to take over from now. So we'll sit down and have a discussion a bit later. Thank you.
Hi, I'm actually really nervous So I've given, my name is Chloe Beale, for those of you who don't know me. I'm a consultant liaison psychiatrist in Hackney. And I've talked about suicide incapacity a lot over the last couple of years, sort of probably into the kind of thousands of people now who have heard me bang on about the subject. You know, we had an audience of about 500 at the International Congress when it was online last year, various people, but I've hardly done it face to face, and I've never done it to my own colleagues. So it's quite nerve-wracking. And I also have to say, right, this morning, halfway through rushing around the hospital trying to see patients, my shoe broke, and my partner had to do like an emergency resupply mission to rush to the hospital to bring me new shoes. And I got to the overground station, which is when I realized there was a strike on. So then I had to sort of rush and get to a different station, lost my umbrella in the process. And after this, I have to rush home and give an online talk at a college virtual event, which hilariously, we're supposed to be convincing foundation doctors they want to train in psychiatry. So that's my day. And so if anybody is particularly challenging or asks me difficult questions, I will probably cry, and you will have to live with yourselves. So on that note, hopefully what I'm going to talk about does make a little bit of sense in context of what Paul's been talking about. So I'm going to talk about suicide and mental capacity, which is a huge bee that I have in my bonnet for various reasons. Obviously, my clinical work is very suicide-y. I am at the moment the Trust's lead for suicide prevention. And yeah, I'm very, very interested in this. So why does it matter? Why are we talking about suicide and capacity? Well, suicide obviously is a big public health concern. There's lots of these zero suicide initiatives, which this is not the forum to talk about them, but you can ask me about my views on zero suicide at a later date. But at the same time, we've got increasing sort of focus on autonomy and self-determination. You know, there's another assisted dying bill passing through Parliament at the moment. There's lots of people sort of very interested in this, and it's entirely possible that at one point we will have legalized assisted dying in this country. So it's a bit difficult to kind of weigh up. We also, there's a really complicated interplay between the legal frameworks, which I'm going to go into a little bit. You know, the Mental Health Act and the Mental Capacity Act can complement each other, but they can also really contradict each other and also be really confusing as to which one you should use. I think that we've already touched on this a little bit, that the law can be really liable to misuse, and I'll go into that a little bit more. And capacity has become a little bit of a buzzword, hasn't it? It's, as Paul pointed out, it's become part of the emergency psychiatry bingo card. And these are all, you know, and I think Paul was quite generous in saying that none of you write these things, because you do, really, don't you? I've done it, we've all done it. The less experience you have, and I'm not saying that this is all like junior doctors, because it's probably not, because believe me, those of us who should know better often don't. But, you know, you've all seen these things written. You've probably written some of them at some point. I'm not going to pretend that I have. But when you drill down into them, sometimes they don't mean an awful lot. They can become sort of things that we sort of use, and it's like these stock phrases that kind of, we think, convey a protective coating and make ourselves feel better about what we're about to do. And I think capacity, in a lot of cases, has become one of those. So sometimes, that's the things covering my title slide, but sometimes the question might arise as to whether a person in front of us has capacity to take their own life. And I think there's two clinical scenarios in which that might arise. One of them is in an emergency setting when someone has harmed themselves already and is perhaps refusing treatment, refusing for future care. And that's something that I talk to a lot of emergency clinicians and pre-hospital medicine folk about. So I do a lot of talk with sort of paramedics and the doctors and the helicopters and all that sort of thing about that sort of thing. What do you do when someone's done something and they're refusing care? But I think that the aspect which I want to focus on a bit more, which is a bit more insidious and troubling and perhaps a little bit more relevant to us, because actually when someone's actually harmed themselves, capacity might not even need to be in question, because a lot of the time the Mental Health Act might cover you. It might cover you to treat the consequences, the physical consequences of an overdose. But I think that what's more troubling is when people indicate that they're suicidal, or there's a recognition that there's an ongoing risk of suicide. and they're told that they have capacity to make this decision. And sometimes that can happen in a crisis situation or in a more sort of longitudinal way, like by a community team or an inpatient team, patients being told, well, you have capacity to make that decision, so it's up to you, in a way, with the intention of encouraging, personal responsibility or positive risk taking. And that's what I'm going to focus on a little bit more. So I think in the emergency setting, particularly if you've got someone who's taken even partial steps to put that intention into action, so having harmed themselves or something, your default position if someone is refusing care in this situation is that you need to do a proper assessment of capacity. You can't rely on the presumption of capacity here. It's too big. Now, determination of capacity, of course, is on the balance of probabilities, and the requirement is for a reasonable belief on the basis of reasonable steps having been taken to draw an opinion on someone's capacity. And I think, and there's kind of minimal case law in this situation as well, which also makes things difficult. But if you're in this fast-moving situation, you've got limited information, it's perhaps a crisis, you might have someone who's probably emotionally distressed, who's possibly experiencing the effects of whatever they've done to hurt themselves. Not taking action is going to endanger life. You're against the clock. You've got kind of limited amount of time before the risk becomes higher, particularly, thinking about something like a paracetamol overdose, you have a window. I think that, although we should never say, you're always going to say capacity or always going to say no capacity in this situation, I would err on the side of saying that your threshold for concluding a lack of capacity in this scenario, someone's refusing life-saving, potentially treatment, having started the process of ending their life, I think your threshold is probably going to be pretty low here. But that's not so much what I want to talk about here. So I'm going to kind of move on from that, because in many ways it's a slightly easier situation that. So why are we talking about capacity in relation to suicide? What do we mean? So as you know, of course, the concept of mental capacity has been around for a long time. But the Mental Capacity Act, it didn't originate with the Mental Capacity Act, but the Act has sort of, enshrined it more into practice and sharpened our focus on the concept of capacity. And it's become more embedded in practice, which is great. But also, as we will see and as discussed a little bit, it also means that it's become a little bit of a buzzword and a little bit of a tick box, because we're all like, yeah, we've got to think about capacity, but we haven't actually got time to think about capacity. We know, of course, that the presumption of capacity is a key principle of the Mental Capacity Act, but I think that what we see a lot of in all areas, certainly see this quite a lot in, my medical patients, is there's a conflation between presumption of capacity and having capacity. So writing somebody has capacity without a documented robust capacity assessment. And this is even more serious than a lot of scenarios when you're using that to say someone has capacity to die by suicide. So one of the problems is that sort of conflation. And I think that if you're writing that someone has capacity for suicide, then you want to make sure that there is a really, really good quality capacity assessment documented, and that it's not just that you've written they have capacity. But I would still question why anyone's initial instinct is to actually think about capacity when there's an awful lot to think through in terms of in a suicidal crisis before you get to capacity. So I would wonder why capacity is even at the forefront of anybody's mind. Because actually the principles that we are bound by and the law that governs us, it's not the Mental Health Act and the Mental Capacity Act that impose obligations on us. It's the European Convention on Human Rights that imposes obligations on us, and the acts are those frameworks through which we can enact those obligations. So when we have patients, and we are operatives of the state, if we have patients who are under our care, who are under, particularly if they're detained, if they're under state control and detention, we have a duty to uphold those human rights. And there's no primacy given in human rights. So technically, very technically, within Article 8, yes, people do have the right to die by suicide if they want to. They do have the right to decide when they want to die. But they also have a right to life, which is Article 2. And yes, there's no primacy given, but you have to use your common sense and think, well, one of these is potentially reversible at a later date and one of them isn't. So I think that, you know, our duties under Article 2, which is to protect life, are going to be our guiding principle when we've got someone in front of us who is suicidal and may die by suicide at some point in the not too distant future. So bear that in mind. If you have someone who is in real and immediate risk of suicide, which is a difficult principle in itself, because as we'll discuss, we're not very good at predicting risk, but the state's operational duties under Article 2 are engaged, and that's you. You know, you are the state in this scenario. So again, principles of the Capacity Act, we all know that people have the right to make an unwise decision, and arguably, you know, philosophical discussions aside, we might often consider that suicide is an unwise decision. But I think that that objectively unwise decision is rather more complicated when it involves somebody with a mental disorder, including diagnosis of a personality disorder, when the potential outcome is death, and it involves someone having taken active steps to end their life. So already that principle, you can see that this wasn't really written with this scenario in mind. And another thing that's important, like we know that mental capacity, right, the Mental Capacity Act is about making decisions on behalf of people who are unable to make them for themselves. And for our purposes as doctors, as psychiatrists, that's mostly care and treatment decisions. You might at some point be getting into sort of welfare and financial decisions, but mainly, particularly in clinical scenarios, we're thinking care and treatment. So I would ask you, if you're sort of thinking about whether someone's got capacity for suicide or other things as well, I get asked questions like, you know, does this person have capacity to assault other patients on the ward? And my question is, well, what's the care and treatment decision? Because assaulting patients isn't a care and treatment decision, and neither is suicide. Somebody's decision whether to go and take steps to end their life, that's not a care and treatment decision on your part. So that's clearer if we're talking about, do we intervene? But the decision here is focusing on the wrong one if you're talking about someone's capacity to die by suicide, because that's not actually a care and treatment decision. You're talking about what's the treatment decision here? What am I assessing their capacity on what they should do? And if given that you would, if you thought someone lacked capacity to end their own life, you'd probably detain them under the Mental Health Act, wouldn't you? But what people are being told is, well, you've got capacity, so we're not going to do what you want. So since when do we only treat people who lack capacity? So people are being told you've got capacity for suicide, therefore I'm not going to help you. Whereas if they did have capacity, we would help them, we would admit them. And that's kind of perverse when you think about it. And if people are asking for help, and you know, we know the sort, let's face it, the sorts of patients we're talking about, the sort of patients who probably picked up a diagnosis of personality disorder, who we may find challenging to work with, maybe who are attending services a lot. This is the kind of person that this is happening to, by and large, but not exclusively. But if people are asking for help in however a chaotic and challenging manner we perceive that to be, you know, to say they have capacity, therefore you're not going to help them, it just doesn't make clinical or legal sense. And this is something that came up in both the earlier on the House of Lords post-legislative scrutiny of the Mental Capacity Act, and also more recently Simon Wesley's Mental Health Act review came up with, you know, respondents to both of those reviews said vulnerable people are being denied care in certain situations under the guise of having capacity. In social care, it was seen in the Mental Capacity Act review, people being left in really vulnerable social situations and social workers saying, well, they've got capacity, because it's kind of easier, isn't it? It's easier than sort of thinking, oh shit, what am I going to do? And I think that some of the issues leading to this, like I've said, it's become a bit of a sort of blanket tick box statement. Like you all know, particularly the more junior of you, I think, will be aware that it's become an expectation that your clerkings and your admission documentation says something about capacity. And the CQC will come in and go, oh, why aren't you something about capacity? They don't seem, in my experience, to care what you say about capacity as long as you said it. You know, so the CQC has a lot to answer for in perpetuating our tick box culture. I'll just say that now. But, you know, so I see these clerkings, and I'm not kind of criticizing anybody here who's doing this, because this is the prevailing culture, and this is the culture that's making you do this. You got your full clerking, your mental state examination, your risk assessment, you know, and then capacity. Has capacity, you know, is able to understand, weigh up, retain, and communicate decisions. And I find myself like a stuck record. And believe me, again, like I work largely with medical patients, of course, and I say this to medics a lot, like, what is the capacity decision? Capacity for what? Capacity is not a blanket thing. And we all know that in principle, but I think the culture is really pushing us towards thoughtlessness. It also gets treated as static. And that's really dangerous. I think that this is something that also comes up, that somebody in some scenario in a CMHT or a ward says, well, this person, she's got capacity for suicide. But mental health fluctuates and decision-making ability fluctuates. And when you've got someone particularly with, you know, emotional instability, impulsivity, particular sensitivity to environmental changes, you know, you're going to get corresponding changes in decision-making ability. And it makes no sense to say that somebody is always going to have capacity to make that decision. So you will find decisions made on the basis of somebody at some point saying, well, they've got capacity for suicide, so they shouldn't be offered admission or whatever it is. And I think that actually this is what Paul said, that we rely on legal terminology to avoid moral injury, and we do this in a maladaptive way. And I think that's exactly what this is, because you know, this is the kind of magical thinking that we use in order to deal with the discomfort of not actually knowing whether someone's going to die by suicide, because we all know we're terrible at risk prediction for suicide. It doesn't work. Risk assessment checklists, we know this, we know the research, they don't work, they don't predict risk. We're terrible at knowing whether people will die by suicide or not. We haven't found a good way of really predicting that, but we kind of pretend that we do because we don't know what else to do. So it's like quantifying risk into low, medium, and high. You know, we can all fall to that sometimes, even though we know it's completely meaningless and may actually be harmful, because we use it to justify decisions when it doesn't actually work and it doesn't mean anything. And I think that there's nothing wrong with a lot of these concepts in principle, you know, like kind of positive risk taking and encouraging people to take responsibility. It's an extension of that. There's nothing wrong with those ideas in and of themselves, but it's when the problems arise when we start using it to legitimize lack of care. And just to sort of emphasize this from someone who knows a lot more about this sort of stuff than I do, or probably anybody here, Professor Lewis Appleby, the guru of psychiatric research in this country, again, would tell you that he hears this a lot. You know, families and carers and bereaved relatives will talk to him a lot and say, you know, they were told that they had capacity for suicide before they died. But it's not quite getting the wider recognition, I don't think, that is deserved, although it is beginning to. Coming on to that. So, you know, this is not just for me, but I think he kind of hits the nail on the head here. It doesn't actually make things safer. And we sort of see risk as low because they have capacity, and use that to justify sort of not doing something, or justify rationing resources because we don't have those resources. So to kind of resolve that moral injury and cognitive dissonance, it's about making ourselves feel better. So really, I think the capacity is a bit of a red herring, and I think that you can approach suicide really in most cases without ever needing to think about capacity. I think it's easier for us. It's easier when we feel powerless and irritated and frustrated. It's easier to say this person has capacity to end their lives than either to do more to help, or to admit that we don't know how to help, or we've reached the limits of what we can do to help. It's much easier to then put the responsibility back to them. Well, they've got responsibility, they've got capacity, they've got decision-making ability, so it's up to them if they kill themselves. And we sort of, again, this protective coating of this pseudo-medico-legal language to make ourselves feel better, to say, it was okay, they've got capacity, it's not our responsibility. And it's easier than admitting that we don't know how to help, we've reached our limits, we can't predict, you know, we're at sea here, which is how I spend 90% of my working day, I would say, thinking, I don't know what to do. But it is our responsibility. You know, like I said, if someone's at real and immediate risk of suicide, the state's operational duties under Article 2 are engaged. So it is our responsibility. I think there's other things that are worth considering and just thinking about, because there's nothing kind of black and white here. These are just my sort of thoughts and things that I would ask you to mull over a bit. So one is that arguably the test for mental capacity isn't great for end of life decisions, where you've got this interplay of pain and fear and distress. it's sort of designed in a way that allows for much longer thought. It's great for thinking about whether a person with dementia can go into a care home, and you've got lots of time to think about that and have a best interest meeting and consult with their relatives and all that sort of thing. It's not great when you're making sort of emergency end of life decisions, but it's all we've got at the moment. I think that the information threshold needed for people to make a capacitated decision is necessarily higher, the graver the situation. So I would really question a clinician, to be honest, who particularly in an emergency scenario feels truly confident in their assertion that someone has capacity for suicide in that situation. I really would. As mentioned, there's a real variation in understanding about an application of the Mental Capacity Act amongst our profession. And so there's a risk that if you say someone has capacity for suicide, somebody else is going to run with that and not think that they have to reassess or reevaluate. And this is a particular bugbear of mine. So, right, we all know, right, the Suicide Act 1961 abolished the crime of suicide. That's why we don't say commit suicide anymore. It's not a crime. But it does make it very clear that aiding, abetting, or procuring the suicide of another very much is a crime. And in the Mental Capacity Act, in fact, there is a clause that says, for the avoidance of doubt, it is hereby declared that nothing in this act is to be taken to affect the law relating to murder or manslaughter or the operation of Article 2 of the Suicide Act assisting suicide. So this is really to kind of cover, to make it very clear that assisted dying is not okay, even if someone's got capacity to ask for that. But I think it's really relevant here. And I think that, in law, there is a distinction between an active act and an act of omission. So obviously, you would be aiding and abetting and procuring the suicide of your patient if you, injected them with potassium or something. But if they're in front of you in the process of dying by suicide, having taken an overdose and refusing treatment or whatever, I think that being a doctor with the tools available to save that person's life, to stand back and do nothing, could be argued as aiding, abetting in a suicide. And I've spoken to barristers about this, and they're all a bit like, yeah, I haven't thought about that, because it hasn't really come up. But actually, the best I've got from someone I really trust is, yeah, that could probably be argued. And personally, that's not something that I would want to go up against a good barrister to argue, and to risk a 15-year imprisonment, frankly. So, I think that is worth considering, that actually not intervening in somebody who is at immediate risk of suicide, it feels a lot like aiding and abetting to me, personally. Now, look, you'll probably, or some of you will probably be sitting here thinking, but what am I supposed to do? I'm supposed to admit everybody who might ever kill themselves because we've got no beds. Even if we wanted to do that. And that's not what I'm saying. In fact, I think that we have a real lack of imagination in mental health services, because we've got this sort of mindset, because of scarcity and because of, how unwell people have to be and everything, that we sort of think that admission is the only thing, like either you're high risk of suicide and we admit you, or you're low risk of suicide and we don't, and that's what we've got. But actually, I think there's plenty of other ways to help people to be less suicidal. And obviously, there's plenty of cases where we should admit people to hospital, but it's not all just about that. And in fact, anyone who's worked with me will know that I am far from being a risk-averse liaison psychiatrist. I'm very happy to work with risk, and I certainly don't admit everyone to hospital who may at some point die by suicide. But I don't think, and I've got a reasonable amount of experience, and I work with lots of suicidal patients, and I've seen patients with every diagnosis under the sun, and I can't think off the top of my head of a single scenario where it's even crossed my mind to start thinking about whether someone's got capacity for suicide. Because like I said, there's just so many other things to go through first, and it's not particularly on my radar. So these are the uncomfortable truths, I think, and this is sort of going back to what Paul was talking about, and is, I think, the crux of it, is that I think that things are pretty shit at the moment, aren't they? Like every day of my working life at the moment, I kind of think, what am I doing with my life? I can't get people the help that they need. There aren't any beds. Nobody takes on outpatient referrals unless you meet increasingly stringent criteria. I feel every day of my working life that I can't help people. So this is a really great mindset that I'm going into this Discover Psychiatry session this afternoon with a bunch of you know, really keen F2s who want to be psychiatrists. It's fucking pointless, don't do it. But I think, you know, all medicine is pretty much the same at the moment. But really, this quote from Lewis Haffby's colleague Nav Kapoor is really key. And he says that well-meaning legislation that legitimizes non-treatment, i.e. the Mental Capacity Act, may be dangerous, especially in a group of patients, and we all know who he's talking about, who some clinicians may regard as wasteful of healthcare resources and undeserving of care. As the Mental Capacity Act is actually supposed to empower vulnerable people and help people make decisions. And I think that is quite a shameful fact that health professionals have begun using it to legitimize taking no action, and further to punish people who we see as difficult and challenging. And often when I talk about this, there's somebody that, you know, gets on their high horse a bit and is like, oh, that doesn't happen here, and I've never seen this happen. And I promise you, yes, we're an outstanding trust, and maybe nobody in this room has ever done anything like this, but I promise you it is happening in this trust. It will have happened to patients, you know, we have given talks, I've done focus groups with people participation here. There are lots of people, if you are willing to hear them in this trust, who have had this, who have been told this, who have been told you have capacity to end your life, and all over the country, people have had this experience, I promise you. And capacity gets, you know, this concept of capacity, at its very worst, is getting used against people. So also what I want to say is just, please don't be that guy who's like, I'm not here, because I'm not, you know, great, if you're perfect, I salute you. But I'm not interested in not all psychiatrists any more than I'm interested in not all men or all lives matter or any of that stuff. You know, if you're not doing it, that's wonderful. Keep an eye out for it, because I promise people are suffering and not getting the care that they need as a result of some of these concepts. So I think that, you know, these are concepts, like I said, they have their place, and however you want to dress it up, like positive risk-taking, you know, encouraging responsibility, discouraging dependence on services, having capacity to make their own decisions. Whilst these are all concepts which of course have their place, they're being allowed to deviate from their initial purpose. And in fact, they've become weaponized to punish patients with whom we feel angry and frustrated. So in conclusion, just some sort of thoughts, maybe some questions, my feelings about this. So capacity, I think, is not capacity when it's used as a false indicator of low risk and an attempt to deflect responsibility for a hypothetical future death. I don't think this is about capacity. I think it's about culture, stigma, fear, and moral injury, and all that juicy stuff that we're talking about this afternoon. I think the Mental Capacity Act has become used in ways that were never envisaged when it was sort of going through Parliament when it was first set up. And there's lots of examples of that. You know, Doles is a perfect example of how, you know, the Mental Capacity Act has not really worked very well. But it's, you know, it's become much bigger than its original intended purpose. And in some ways that's great, because it should cover lots of different decisions, but in some ways that's really quite dangerous. And my view is that the Mental Capacity Act, or the test of mental capacity, is just not fit for purpose if we're talking about suicide. And there's just too many variables. There's too many other principles before you get to that place. And clinically, it doesn't particularly make sense to me, and certainly not in an emergency situation if you're not talking about a care and treatment decision. And of course, just to hammer that home, suicide itself is not a care and treatment decision. It's not something that we should be assessing capacity for anyway. And my final point is really, you know, you don't have to listen to me, because I'm not the only person talking about this. So you might kind of think, you know, well, this doesn't happen here, it doesn't happen in my team, and my trainees don't do it, and nobody does this here, and everything I do is wonderful. But I encourage you to read about it. So the barrister Alex Ruck-Keene, whose work many of you will be aware of, I'll get these slides sent round, so you don't need to take photos of them in their clickable links. He is expert on capacity law and wrote an excellent blog on capacity and suicide in 2020. And it was sort of subsequent to that he and I and actually someone from the service user group from the Mental Health Act Review did a session at Congress about this. The excellent academic lawyer Lucy Series has written a much more recent blog about the "you've got capacity to choose your kill yourself" phenomenon. and some very useful links in there. And finally, this is a really neat piece of survivor/activist research looking at people who've been through mental health services, 200 people, and have been told about, having capacity to kill themselves. It's uncomfortable reading, but highly recommended, because nobody's giving anybody research grants to look at this, so it's very easy to dismiss and go, well, I haven't seen any academic papers on this, but it's not the sort of thing that people are funding research into, really, is it? But I recommend reading that, and of course it's very telling that this is called If You Are Not a Patient They Like, Then You Have Capacity. And just finally, that brings me to, again, emphasize Paul's point about ethics committees and that lack of patient voice, because actually, like I said, if you go out there, respondents to the reviews, survivor and activist, writing, blogs, magazines, talks, it's all out there. This is not an uncommon phenomenon, and something that lots of people are very, very familiar with. And sometimes we have to sort of step outside our own little sphere of, reading the yellow journal or whatever it is that we do, or if you're me, leaving it wrapped in plastic and intending to read it one day. But there's a lot of this stuff out there, and it's not unusual. And I think that how can you talk about ethics without having the voice of the people who are affected by our decisions? So I think that that's incredibly key, and something that for some reason we're a little bit avoidant of. So I'm going to leave it there. I have no idea how long I've been talking for.
A little bit of time. I don't know how this Zoom works, because I can see someone put their hand up in the middle of it. So if the person who put their hand up, who I think is Shauna in Luton, if you can speak and we hear you come from the ceiling, that would be great. If we can't, maybe put it in a question, and we can discuss the questions after the break. I know Shauna, and I'm not hearing her voice coming from the ceiling. So Shauna, maybe if you could put yours in the questions here, we maybe have 5 minutes before the next session to talk about it. Because I think there's a couple of questions from before.
Is it a touch screen?
I think we might look at these in the break, and we'll come back to them just before Richard's, but maybe some questions in the room.
Yeah, that's a good idea. Yes. Thank you. Could I ask you to project a little bit, and other people at the back to whisper a little bit less, just while we're talking?
Just say, really good talk.
Thank you.
My question was, with regards to your talk with your barrister friends, and whether or not people sent to jail or not taking capacity seriously and detecting suicide. Do you think it will take some legal precedent like that to take capacity seriously?
I think it's very unlikely that it would happen anyway, because the whole process of taking things to court is, it's very skewed in favor of privilege, and there's lots of things that don't get to court which probably should, and other things that go to court which possibly shouldn't. God, I hope not. I think with legislative reform, we've got a real opportunity to get people a little bit more interested in their legal obligations and the law. I mean, I sort of find it baffling that people aren't fascinated by the law, because I'm really sort of embarrassingly nerdy about it, but I get that not everybody thinks like me. But yeah, I think, and which is why I think ethics committees are a great idea. I'm just like, I want to be on the ethics committee. It's really cool. I'd like to do that on a weekend. It sounds like so much fun. So I don't know, but I think that we can all think more in our teams and in our jobs about how we engage each other more and how we make this more of a conversation. So I hope not. And it is encouraged, it's being talked about more, like, these pieces of writing and the talks that I've been giving and Alex has been giving are all in the last 2 years. So there's a bit of a groundswell and more people interested in this. So I think that we're getting somewhere, I hope. Yes.
If suicide is not a treatment case, why we push so hard to bring people in, not let them go home, but if they go home and their life, we could be taking up the register, we could be
Because admitting them to the hospital is a care and treatment decision. You admit them to hospital to treat something. So that's the treatment, but their suicide, their actions are not the capacity decision, it's the treatment that you are giving. So saying someone's got capacity to end their life is the wrong question. Yeah, but it's perverse if we say, yes, they've got capacity, therefore they're not getting it. Phil, oh, sorry.
I just want to ask, I guess, given the role of misogyny
Strong. in a word, yeah, you know, I think it sort of goes back to hysteria and things, doesn't it? And not kind of taking women seriously. I mean, you know, institutional biases are all over our services, and we perhaps talk a little bit more about institutional racism because it's a little bit more the focus of the Mental Health Act review and stuff, and obviously it's a huge problem, but I think that we like to maybe focus on just like one institutional bias but ignore the fact that there's others as well and the fact that they intersect. So yeah, I think it's absolutely enormous. Phil?
Both fascinating talks. I've got a question for each of them, that's quite. I want to use a simple one probably, which is, do we know yet what current decisions to deprive
Okay, I'll answer first. I don't know about specifically capacity. There's been quite a lot of inquests where it's been part of an overall picture of patients being failed that I'm aware of. And again, it's generally these young women with personality disorder diagnosis, often ASD as well, lots of suicide attempts. And it's in that kind of the mix of positive risk taking and all that sort of thing. So I think that there's been criticisms, not necessarily specifically of the capacity decision or the capacity question, because I think that because coroners are lawyers, they will often be quite black and white about that. And their view might be, well, if they say they've got capacity, that's a legal, that's a legal statement. And there's sometimes an assumption that a capacity assessment has been done. So I think that sort of in the round of general treatment, but I'm not sure that coroners have necessarily cottoned on to some of the nuances of this, which is something that you might say about coroners in lots of other scenarios as well.
I wonder if it's not always that, it's just sometimes when you're trying to make a decision about route to take feels forward danger. It's the need to protect yourself as a clinician and the feeling not about defense, and in some way is an evidence could that be a function of the clinician defend themselves from future. I think we all fear.
Yeah, and I mean, my caveat, my admission is I thought I came up with that moral injury thing whilst I was doing the slides. I now realise I lifted it from your magical thinking moral injury. So I didn't think of that while that was happening. That was placed. I'm like a rock band plagiarising the Beatles or something. Yeah, actually, I would agree with that. And potentially they're two sides of the same coin. You're a clinician, and it doesn't feel right. And you can frame that as my license is on the line, or you can frame that as I can't sleep at night, and it's often you can't sleep at night because you're worried your license is on the line, but your alarm bells are going off. Definitely in the other ethics committee in the general hospital that I worked at, some of the more blunt clinicians say, I've had to come to you because I'm worried I'm going to get sued. So I'm coming to you. I'm not sure an ethics is that helpful because we're quite wishy-washy and have you considered, have you thought about? But some of them will explicitly say that I could get sued, so I'm coming to you, or I've been told that I need to get a second opinion from you guys. So I think it is, but to be generous, I think that's your ethical alarm bells, your moral injury bells, and your legal bells all being connected by string.
Just for the people online, because the point's been made in the Q&A that they can't all hear the questions in the room. So that was an answer to a question about whether using an ethics committee might in fact be a sort of defensive action. I've only just managed to find a way to join to get the questions in the room and questions from online, and apologies, I obviously can't get the ones that were posted before I joined, but there's one here which there's a couple of comments, and this one is a question. So ethics committee, this is a comment and then a question asking for comment. Ethics committees need to be a regular part of running any institution, NHS institution, and benefit from funding and incorporating in job planning. It's for you, I think. Huh? Ad hoc and reactive approach will not help. US hospitals lay emphasis on this aspect and leave it to senior academics to spare, or senior clinicians, I suspect, spare clinical time of clinicians who are paid differently to how we are reimbursed. Any comments? So I suppose that's a point about it's all very well having a clinical ethics committee, but people just don't have time for it, and should it be a necessary part of our practice?
Yeah, and I mean, that goes back to one of the criticisms is if you're going to do ethics committees, you can't do it, well, you shouldn't do it on the cheap. Like, you need service user involvement, you need time to read the papers beforehand, and you need a quorum of expertise that are going to be guaranteed each of those meetings, and that's hard to do. But yeah, I think probably the worst thing you can do is a halfway job at an ethics committee where you're pronouncing some great ethical principles, but actually you've just looked at a piece of paper and you've speculated what you remember from your LLM. So yeah, I mean, I think that would be my answer to that, and we might discuss that a bit more.
Essentially, we haven't got the time or resources to be ethical. Is that right?
Well, I mean, you have in yourself. I mean, you may not in yourself, but there's something about the way that one of my first slides said that it's a collective discussion in a structured way with all the right people in the room and all having a fair chance to speak. And that's what an ethics committee essentially has to be. However you frame that, you want that's the core feature of it. And the time to do that is hard.
This is probably a relatively quick one for you to answer, Clay, but not a silly question, which is how it's introduced. But are you saying that psychiatrists are actually documenting in medical notes that patients have capacity to commit suicide?
Yes, as are psychiatric nurses and other professionals.
Okay, so I thought that would be straightforward. Sheena had, as well as helpfully raising that they can't hear the questions in the room, which we suspected, that I think this is more of a comment. Occasionally, I'll read the whole comment. Occasionally, luckily only occasionally, one does see people who've made a definite, carefully thought through decision to kill themselves. In that scenario, they are normally too sensible to talk to a mental health professional about this, but occasionally they do. This isn't a crisis scenario. At times, in the context of chronic illness or long ongoing experiences of trauma, there may not be any obvious mental illnesses to treat. With the lack of legislation, I will usually offer a home treatment and hope for the best, but it is a very difficult decision-making process. That's a comment. Have we managed to get the other ones up?
And we can't scroll through these so well. So Dr. Blacking, who I also know from up in Bedfordshire, your question stopped halfway through, unfortunately. It does seem to be advanced decision users to care. I was wondering, as it becomes more and more difficult for psychiatrists and doctors to appreciate compatibility of differing legislation, and then the question cuts off. But I guess there is something very interesting about advanced refusals of care. My bit of knowledge on that is when there's discussions around Mental Capacity Act and Mental Health Act being a fusion law, in which I think there's a state in Canada that has something similar to that.
Northern Ireland.
They struggle with these advanced decisions that you can't object to detention, but you can object to some forms of treatment. So you've got people who are unwell, detained, but their advanced decision has a way to stop the treatments. And there's a real difficult situation there where it's clearly unsatisfactory, but the two principles are clashing against each other.
And I think that what's key in this scenario, and you know, for the previous comment as well about people who have sort of thought things through very carefully, is the question of time. Because actually, yeah, the law does say the you know, human rights says that you do have the right to make the decision as to when you die. And there may be, it's not to say that nobody should ever be allowed to make that decision, but it's about why you're making that declaration and under what circumstances. And somebody who's got a personality disorder diagnosis, who's in and out of hospital a lot, or who is in some way challenging us, or is, you know, otherwise mentally unwell, or is in a crisis or whatever, that's quite different to helping somebody make that decision and that advanced decision in quite a well thought out way, when you've got the time to gather legal advice, to do a really careful capacity assessment, to think about whether there's any other steps, to go to your ethics committee if you've got one. You know, it's not to say never, but the key is about time. And if you're in that kind of urgent scenario, or if you're saying it in a, you know, I think in a ward round or a CMHT, when, well, you know, that's your decision because you've got capacity to kill yourself. You know, that's the scenario that I think that this is more often happening.
I think there's something as well, because some of those urgent scenarios are likely to occur. And there is a temptation to say, well, we have to make a decision now. Of course, there's no possible way we can consult an ethics committee. We've got to go for the sort of obvious decision in these circumstances, but particularly with self-harm and suicide risk, it is likely to occur. So a case I got involved in years ago was a man who self-harmed, but it was complicated about Mental Health Act, Mental Capacity Act, and it was about blood transfusions. And that was heard, and legally heard rather than an ethics committee, but that was all heard in anticipation of this happening again. There are circumstances like that, I think, where you shouldn't just assume that, well, this needs to be a decision now. We can't think about this. There was a question here, but I think it may be a little ambiguous in terms of answering it, but it's for Chloe, would you recommend thorough capacity assessment in every assessment then? Is this always feasible? I suppose it depends on capacity to do what. It depends
every assessment for what. I think that if you never write someone has capacity for anything without documenting a capacity assessment, because that's nonsense. Yeah, it depends what the decision is. I mean, certainly not for every single decision that every single person makes. I mean, that's unfortunately the situation that we've ended up in, where capacities become meaningless because everyone's kind of going, oh, I've got to say something about capacity for everything. So no, but if you're thinking about capacity and you're writing something about capacity, then you've got to do the necessary steps to come to that decision.
Just the first few people who posed questions online, because I can't see them, if you just cut and paste them, post them in again, then we may be able to take those. Any more questions in the room?
There's one here with message of hope, potentially from Dr. Leslie. I was suggesting that maybe we didn't make use of the ethics committee because we've got maladaptive moral injury coping mechanisms. Dr. Leslie's saying that actually in psychiatry, particularly for trainees, there is a very good supervision structure, far better than our general health colleagues. And potentially that's part of it, that we have developed adaptive moral injury protective mechanisms in psychiatry, and we should probably be aware of the good work we do as well.
But also highlights why we need to look after our nursing colleagues and other health professionals, because not everyone working in mental health care is a psychiatrist. In fact, most of the frontline care is not provided by doctors. And we're very privileged as doctors to get all of this. We get to sit in a lecture theatre and chat to each other about ethics. We get to go to Ballant groups and reflective practice and case discussion groups and potentially ethics committees. But we're not the ones on the wards 24/7 or carrying out most of the crisis assessments in A&E. So this is stuff that's being said and done by mental health nurses and other professionals as well, but also people without half the kind of supervision and CPD structures that we have. So also, you know, it's not just about us. We need to look to our colleagues and support them as well in other health, you know, the other health professions that aren't medicine.
I think that might be a good time for a break. Thank you both. I should have bought a bag of ice and thrown ice cubes at you in the second half. Okay, hopefully everyone online can hear us. This is going to be a bit more interactive, and it can be interactive in whatever way you want. It's partly to try and get some feedback, some sense of why we might not have had much uptake from the Clinical Ethics Forum, Clinical Ethics Committee. I've used Forum here, but we'll use them interchangeably. And you will need your mobile device for anyone who's not spotted that this is a Menti thing. So you have to go to the browser on your phone, and this applies to people online as well. You don't have to use your phone if you're online, but you will need to open a new window. Go to menti.com and enter that code. You should then get the first slide. I suppose I should try it myself to check it works. But I'm encouraging you to ask questions as we go along here. The slide, you'll get some messages if you're on that website inviting you to change the slide when I've changed the slide. So let's see. Okay. So this one is a real question, but I asked this just to check out if it's working. It's quite a long question. Is the prospect of recovery in some people with psychiatric conditions futile, so there should be some comments in there, futile so that palliative care is appropriate? And let's see, we're getting some answers. This perhaps does link to Chloe's talk and that sort of sense that sometimes people feel a bit hopeless about what to do, and certainly links to some legal cases in the last couple of years where the Court of Protection has authorized that treatment is withdrawn from people with psychiatric disorders on the grounds that it's not in their best interests, even though death is the likely outcome. Okay, so people have got the hang of it. We're looking at 50, 60 people in the room, seem to have got it working. What I'm going to do is I'm going to go through, there's a variety of questions, a couple of scenarios, and at times I might ask you for some sort of text answers. One of the advantages of this for us is that we will collect some data from a sample of people, and it's probably the free text parts that give us a bit of a sense of what happened with our clinical ethics forum. You should have an option to move on to the next slide. Okay, good. This one's fairly obvious, I think. I think we've already talked quite a lot about what counts as an ethical dilemma. I think there is a tendency for us to think if there's a legal route to a decision, then there is no ethics. And I think that is something that we risk hiding behind. And I speak as someone who is interested in law and often seek solutions from the law. Okay, good. So most people are at least acknowledging encountering ethical dilemmas on a fairly regular basis. Let's ask this question now. To what extent do you think you would benefit from expert ethics consultation? In other words, despite what we know about the uptake, how many people think that a clinical ethics forum or clinical ethics committee in the way that Paul described might be something that would be useful for your practice? Okay, good. Here we go. Is the first step to us reinstituting the Clinical Ethics Forum in East London. Okay, this one's slightly more complicated. You should be able to answer multiple things here, but which of these things would influence your decision to use a Clinical Ethics Forum? So in either way, whether you chose to or chose not to. So a degree of familiarity with what the clinical issue was, confidence that what you were going to do had a legal justification, they're not detainable, uncertainty about what an ethics forum is actually for, fear that you may be obliged to act in a way you don't believe to be clinically justified. In other words, fear that the clinical ethics forum is going to say, do this when you don't want to do that. Is anyone bold enough? 7 people or 8 people are already bold enough to say that the reason for, one of the reasons for using a clinical ethics forum or not is an avoidance of any scrutiny of decisions that you want to make that might actually be criticized in a clinical ethics forum. Okay. Apologies for those people giving this some deep thought, because I know I'm rushing through it. And there may be other things, and I will give you hopefully some opportunities to put down anything that you think is relevant to this discussion. And again, please interrupt as well. It doesn't all have to be Menti. Okay, I think this one is free text. Yeah, so if you've got any thoughts that you've had today about why do you think we did have such low uptake of the Clinical Ethics Forum in East London? Why, given that it was advertised, some of you may say, well, I didn't know about it. There you go. It was advertised, it was supposed to be disseminated through clinical directors. That's interesting. And there's quite a lot of it there. If you did know about it, perhaps think about why it wasn't used, or also if the clinical directors knew about it and it wasn't advertised within services, why was that? So anything that you want to add to that? So most of it is about people not being aware of it, which is interesting, which probably says something about the way we advertise these things, because it was on the intranet, it was in the trust newsletter. And
the only thing is, I wonder whether it was advertised a lot at the beginning.
Yeah.
It's been now 2-3 years ago. So if you joined the trust in the last 2 years, maybe that.
Yeah. So that's a fair point. So Paul just made the point. It was probably advertised a lot. April, May, June 2020 when it was first created. Okay. Clinical directors weren't aware of how to access it. Well, that's problematic. So I think let's have a look at some of the other things. So there's lots there about awareness of it existing. That's not one for you to say to the foundation doctors. Most doctors are not self-aware and do not care about ethics. Speak for yourself. Okay. The term might seem a bit lofty. I think that's a fair point. That's, if you refer to it as a clinical ethics forum, perhaps or clinical ethics committee, maybe it does make it seem inaccessible. Time, how to use it, as well as knowing that it's there. Different frameworks for complex decision making. I wonder if that is about in law versus ethics. Okay, time constraints. Okay, good opportunities to discuss ethical issues within teams. So that is something, I suppose that's the potentially positive and negative thing that's already been referred to. We can sort of protect ourselves from decisions that we want to make that might not be wholly based on good or sound ethical principles, but equally, that might be a really good way to make ethically justified decisions by having lots of people involved in decision making. Lack of concrete advice. Well, that's interesting because a good clinical ethics committee probably isn't going to tell you what you should do. It's going to tell you what you might do and what things you should take into consideration when you make a decision about what you do, which might not feel very helpful. And I suppose allied to reflective practice, isn't it? When you're involved in reflective practice and people bring something to reflect on and then they want to know what they should do at the end of it. There was quite a lot going on. Yep, that's a fair point. Okay, all right. Thank you. Yeah, either or both. So people had any experience of these in acute trusts when they were medical students? It's interesting, isn't it? Because I suppose, maybe because I did my psychiatry training at St. George's, which had a big culture, clinical ethics committees, I was aware of them. But mostly what you would do is you would make a request at a clinical ethics forum, and we never got far enough to say what our model was, but you would make a request at the clinical ethics forum with some outline clinical details and what your dilemma was, what the decision was you wanted to be discussed, and then you may well be invited to come and provide more details. But often it would be, there may be a sort of a degree of discretion about the way it was actually done. It's usually, though, framed in the form of a decision. That's, I suppose, the main thing. It's more complicated if you get something, I think, certainly was from our sense, from our point of view, if you just get, please give us some ethical advice about vaccinations. That's a big question. Whereas if you have a specific case with some specific clinical details, then yes, it's more straightforward. Okay. Now, this one, I think you will get the sort of secondary clinical details. If you're looking on an ordinary internet browser, not on your phone, this sort of question, you have to hover over the first bit with your cursor, as I've done on the screen. So this is deliberately a relatively common clinical scenario. A patient with borderline personality disorder admitted for the 7th time in a year after cutting themselves. The patient is asking for inpatient treatment for their personality disorder. They say they cannot be discharged home again because they do not feel safe. Is this a scenario where you would consider seeking advice from a clinical ethics forum? Now, I accept I've given you the opportunity of maybe, and all of those people will be saying, well, it depends on what the other clinical details are. But the idea is that this is a relatively common clinical scenario. Hopefully you will have something in mind and you can think about whether you might in that situation. But perhaps more importantly, this is just to get you thinking. So keep this in mind, and I'll move on to the next slide. I'm sort of interested in, and again, please feel free to shout out if you don't like this impersonal method of collecting this data. But the next slide is essentially why. Why in that previous scenario did you answer as you did? And I accept the need more information point, so you're welcome to put that down, but why would this be something you did or did not think you would seek advice on? Okay, so it's clinical, not ethical. You might have to make a decision in the moment, you're on call. You'd be taking too many cases to the committee because this is too common. So this is important to get an impartial second opinion. So using the ethics committee for a second opinion. Familiarity with the case. I suppose people are saying, I know how to do this. I know how to make decisions. No need, patient not safe to be discharged. Okay, so the decision's easy. I suppose it's one of the things that's changed in terms of ethics. I wonder if one of the things that's changed is in psychiatry, or maybe in medicine generally, we used to have a sense of we've got to make the right or the wrong decision. And actually, ethics sort of encourages you to think about that there are a variety of possible decisions. Spreading the risk, again, predominantly clinical, not ethical. Decision needs to be made quickly. I suppose I've made that point before. It's happened 7 times already. It might be something you take to a clinical ethics forum because it's going to happen again, even if in the moment you have to make a decision. Too common. Might it be a useful tool in collaborating with the patient, helping them understand your considerations? Maybe 1 or 2 discussions about cases so people are aware of important cases. So lots more about it being common and therefore not necessary. Some people saying they would seek a second opinion. The risk of suicide means there should be not an ethical dilemma. I mean, I would say it is an ethical dilemma, but whether or not you need a clinical ethics forum is something different. Might be a bureaucratic way of managing the responsibilities. So in other words, you should be able, this is what we're trained to do. You should just be able to do this, I think. Okay, well, thanks. Lots of answers there. We will make all this available, by the way. So I know you can't see every answer. We'll send these around if people are interested afterwards. Okay, so same thing again. Relatively common scenario, patient with difficult to treat schizophrenia detained under section 3 is refusing treatment with your preferred antipsychotic medication. Your opinion is that they do not have mental capacity to decide to refuse that treatment, and their treatment plan has been certified by a SOAD. They are adamant that the proposed drug causes them unbearable side effects. Is this a clinical ethics forum scenario? Now I'm going to have the reason slide each time, but I'm going to give a bit less time for it because I can imagine we're going to get some similar themes, but I'll let you answer the first one. So we're pretty evenly split there. I partly put this in because there's a debate going on at the moment with the Mental Health Act draft bill. And there was a recommendation in the government white paper that patients should have the right to apply to the tribunal to have treatment, a specific treatment reviewed. And that decision would be reviewed by a single judge, not a full tribunal panel, but a tribunal judge. And in the draft bill, that has been omitted. That is not there in the law that they're proposing. But there is considerable disquiet about this, and there is a strong patient advocacy voice saying there should be some way of patients being able to have their treatment reviewed. And one of the things that's come up in some of the discussions I've been having has been, this is the kind of thing a clinical ethics forum could contribute to. Okay, so why did you answer that one? You've got any, if it's the same things as before, that's fine. You know, it might be if it's common scenario. If you've got anything specific here that you think, okay, people are getting more succinct now, clinical. Clear, okay, we've got a debate going on there. Has anyone seen the new play at the Old Vic? Yeah, the Old Vic. Oh, Eureka. It's worth going to for the first half, where there is an entire scene that is played out a bit like this with people, but in a chat forum, and it's very, very carefully done and very, very funny. Would contemplate going. Hopefully we won't get a fight here. So, side effects are subjective. Well, that's true. Self-protection. SOAD and the statutory consultees would be the three wise people, three wise men. Yeah, I agree. It would take ages to go through a committee with each patient. It's not very common, is it? Maybe it is. Okay. Why are we trying to give someone a medicine that causes unbearable side effects? Well, that's a reasonable question. Your preferred antipsychotic? Yeah, well, that was a bit provocative, so well done picking up on that. This is also something that the Mental Health Act is going to try and introduce, which is interesting, which is, I think, law for clinical practice. Now, you could argue we already have law for clinical practice, but the Mental Health Act changes are proposing almost a checklist of things that doctors have to do when discussing treatments with their patients. I think it's a bit embarrassing for psychiatry that this is considered necessary, because it's a list of things we probably should all be doing. And I think the fact it's there suggests that we're not all doing it. There you go. Okay. Thanks. There's a variety of things there. Okay. This maybe is a bit more weighty. Patient with diagnoses of mild intellectual disability and borderline personality disorder is an inpatient on a medical ward refusing nutrition. They have been assessed under the Mental Health Act and are not detained. There is agreement that they have the mental capacity to make decisions about nutrition. The case has been referred to the Court of Protection, essentially for a ruling on what should be done. Is this a clinical ethics forum scenario? Okay, so we probably got more of a bias towards people suggesting this might be a case they'd take to a clinical ethics forum. I'm going to move on. If you haven't placed your bet. Okay, so why did you answer in that one? Yeah, so it's the complexity. It's tricky, isn't it? Because we have become a bit sort of anesthetized against what we're doing in terms of the previous one was about giving someone a treatment that they absolutely do not want. And yet we say, well, that's common. We do that all the time. So it's the complexity here that is the problem. Yeah, so someone has picked up on something here. The Court Protection must trump the Ethics Committee. Of course, that's right. So there is a question here is what are you asking the Clinical Ethics Forum to do if you have a legal decision being made? Ethics learning points broader than any court ruling. Well, that's interesting because, of course, a court decision is only on the individual facts of a particular case, and it will hinge usually on a specific point, whereas it might not consider morally what's right in the round. Okay, legal frameworks don't fully solve the problem. It would go to the media and the courts, so we want multiple opinions. Yeah, some comments on the actual clinical scenario. Legality clear, clinicians want to discuss different medical specialty input. Okay, yeah, so there's all sorts of, I suppose complexity is probably the takeaway message there. Now, there's not many more of these, might be the last one. Okay, 76-year-old patient in A&E with a UTI is referred to psychiatry because of concerns about hallucinations. They are not distressed by them, and their partner tells you that their memory has been deteriorating, but they're managing okay at home. They ask you not to discuss the memory problem with the patient because the patient is terrified of developing dementia like their parents did. Is this a clinical ethics forum case? So this is a confidentiality question. Apologies to those psychiatric specialties that have not been represented in these examples. I'm a forensic psychiatrist. We don't look out of our ivory towers very often. Okay. All right, you might have run out of enthusiasm for putting in comments, but let's see if you've got any more thoughts about why did you give your response to that. Don't see how ethics would get involved. Makes it sound like ethics is a sort of a person. Approach is described in good medical practice. That's true. So good medical practice does include some ethical principles. So patients have the right to know their diagnosis, whether or not they have insight or capacity. Well, of course, that's one particular point, and that in some ways, I don't know if that's an argument for or against a clinical ethics forum, but that goes much more towards the idea that there must be a right answer here. And I suppose that's the question. Is there a range of possible answers? You'd be on shaky ground. That may be true. It's complex and fundamentally ethical dilemma. So we're getting sort of polar opposite opinions from some of these comments. Some people are saying, nothing to see here. Don't see what ethics has got to do with this. And some people are saying complex and fundamentally ethical. That in itself probably tells us something. Confidentiality issue, you'd find a way through. And I'm sure a lot of people would, and think about it carefully. I've written an essay about it, so I know what to do. That's a good one. Okay. It's an ethical dilemma, but one with clear laws surrounding autonomy and confidentiality. I don't need a committee to tell me what I might do here. Yeah. Okay. Oh, sorry, I did have one more. Yeah, I quite like this one. I think that's a short one. Patient with antisocial personality disorder has repeatedly damaged property, let's say at a CMHT, and threatened staff who want to ban them. Is this a clinical ethics forum case? Has anyone ever been involved where a patient has been banned from attending somewhere? Yeah. It's funny, isn't it? That is normal. Okay, that's interesting. So we've got a bit more bias towards saying yes to the clinical ethics forum here. So I will withhold my hypothesis about what the reasons for that might be, but let's see. Oh no, I didn't give you reasons in that one. Okay. Okay, let's having done all that, and I might have primed you here, are decisions you and your team make ethically informed? I feel like I need to sort of see the people who say rarely, because they must be unhappy in their work. Okay, all right. And finally, before we can open it up for questions, is there a place for a clinical ethics forum in ELFT? There's no maybe here. You've had everything you need. Dr. Baker's left, so I think he was the most senior person in the room. Okay, well, someone's going to put no now, just to provide some balance. Okay, Thank you very much. Let's open it up to questions for everyone. If there are more thoughts or questions for those people who are online, you will not be appreciating quite how hot it is in this lecture theatre. So that might be the only question. Please, can we go outside? But yeah, any more questions that people want to ask? Yeah, at the back.
Right, well, this is what we thought. This yeah, and obviously not this side of this test that in this situation these were the way conditions.
Yeah, so the question is about what actually happened as the outcome from the clinical ethics forum if someone takes a case. And I suppose what Paul and I would probably say is we didn't have enough cases to really establish what format it would take. We talked about the structure, and what should happen with a clinical ethics forum report is some form of written response that describes what the different decisions might be, and to then provide a structure for thinking about the way in which the final decision should be made, rather than giving a sort of an indication of what the preferred option is. Of course, there are going to be certain scenarios, and we had this with our discussions, where you express surprise that someone might even be thinking about this possible course of action. But of course, I suppose that relates to that notion of the adversarial position. It's quite good to take an alternative position and then sort of question that alternative position. And I wonder if that's just something that people don't have time to do, or it's hard to do if you've got a particular view about what should be done. And maybe that's a good trigger for thinking about a clinical ethics forum when you're too certain about a decision that has significant consequences. Maybe that in itself would be a good indication. But I think in terms of what ours look like and what the format would look like, I don't think we didn't do enough to really establish that. I wrote one of the responses, but it was more of a generic question. I think it was the one about leave from the forensic service during COVID, but it wasn't about a specific scenario. So it was a more generic set of principles.
Two examples that I think of. One was around being banned from A&E, and I think probably what our response was, we expressed, that was when we were surprised and sort of suggested that flexibility and being able to review things is a core principle in practice. And this didn't seem to have that present. So I think that was sort of saying there's this big ethical principle that the decision making in this doesn't seem to quite fit. You may want to think about that when you're making a decision. And another one that I brought, which was about someone, the question about, do you transfer someone to London from Luton Hospital against their wishes under the Mental Health Act, that kind of stuff. That was more sort of, when you presented it, did you think about the risks to other people while they were still in Luton Hospital? So that was more about just sort of, did you think about things rather than essentially saying, this is a really difficult decision. These are some of the things that you might also want to explore that you didn't bring up. So far more, this is complex. We back you up. This is going to be a hard decision. Here are some extra things that you might want to think about. And the other one was more constructive.
I'll just deal with the one that was online because it's someone who missed your talk, Paul. So summarising the role of the Clinical Ethics Forum in 3 or 4 key points. So I suppose the main focus is about clinicians being able to take individual cases to a Clinical Ethics Forum where they have a particularly, where they feel that they have a dilemma, and they would be seeking support for the decision-making process rather than a solution as to what they should do. And they would expect the Clinical Ethics Forum to provide them with some structure to thinking about that complex decision. The follow-up was, would there always be a legal representative on the Clinical Ethics Forum? There was not a lawyer on ours. There were mental health law representatives. And I suppose the reason I was there was mainly because my interest in mental health law. I'm not an ethicist at all. And I know that the South London and Maudsley one, I think Alex Keane, who Chloe mentioned, is actually on the South London and Maudsley Clinical Ethics Forum. So they do vary, and the St George's one that I've mentioned was for a long time chaired by Nigel Eastman, who was actually a forensic psychiatrist, but also a qualified barrister. So there was a sort of strong legally, or a sort of legal drive, I suppose, for some of these things. But I think what all the lawyers would say, all these legal representatives would say, is that they're there because they want to emphasize that law cannot answer ethical questions. And so they're there to sort of say, yes, this is what you might do lawfully, but there is a question of ethics. Sorry.
I think a lawyer on there sometimes is quite useful with saying, look, this is court of protection level stuff. So with those capacity ones, like, we can debate the principles, but by the way, this probably should be going to the court of protection. And again, that's not really the ethics of it, but it is useful in giving feedback to staff and providing them with sort of being pleased with the outcome, finding it useful. But that isn't an ethics thing.
It was mentioned at the very start, everyone should listen to the sort of back episodes of Inside the Ethics Committee, because I think the sort of nature of the discussion there helps understand where this fits in, because I think there's a real danger that we go, well, I know what we can do here, and I know what's legally permitted, but it's a question of what you should do. It's much more of a moral question. Yeah. It's an interesting question. So the question is, has the clinical ethics forum ever been used with the patient, particularly where there's disagreement between perhaps the patient and the clinical team about what should be done? Has the clinical ethics forum ever been used in a therapeutic way? I think that's potentially one of the things that they've been criticised for not involving the patients enough. I have forgotten the name of the child that was at Royal London recently who died, and there was it was a legal case, and I imagine that there was a clinical ethics forum discussion about that case, but what seemed to have happened in that case, that there was quite a poor relationship between the health staff and the family of this child, and I think it's potentially it could be, maybe not the actual clinical ethics forum itself, but the structure. The clinical ethics approach might be a helpful way to think with families, patients about decision making. So, I mean, there's nothing to say it has to be in the format. We don't have to mimic what's happened with clinical ethics committees in acute trusts. We could say we need some kind of clinical ethics forum, and we'd have a different approach where it sort of does involve the patient, I suppose. Yeah.
Give support advice, or in some way is it like an ethics watchdog or something like that, where it actually scrutinizes the ethical decision making of a trust and in some way is independent of the clinicians, has that slightly adversarial.
Yeah. So I haven't thought about it in that latter description. Sorry, I should just repeat the question. So the question is about what do we see the role of a clinical ethics committee being? Is it more, I suppose, is it more a supportive function for people to make decisions, or is it more about a sort of more as an ethical watchdog? I think you described it as, so a sort of scrutinizing decisions that are being made and probably having a more formal role in a governance structure within an organization. I think my view is it's more about the former role. Its success should be measured by whether clinicians find it helpful in making decisions, and that it shouldn't take on some kind of ethical watchdog scrutiny, because I think that we're saying that we're saying it's quite hard to know what the right and the wrong decision is. And if you start to do that, fulfill that second role, there's a real danger that you create a situation where the ethics committee pronounces on what the right or wrong decision was. And so I think and this is why we're asking the question, why didn't it work? And we didn't quite get the uptake to really test whether it works. But Paul's example of people coming back again to the one in the acute trust suggests that some people find it useful at least. So I think the role for me is about helping people structure their decision making. And just anecdotally, I think one of the most difficult things is explaining why you've made a decision. People are very good, I think, at expressing what their decision is. I used to do some training for nurses, and I used to be on it called high risk decision making. And it was a scenario, and it was based on a real scenario that happened, which involved the death of a member of staff. And I took them through this scenario at each stage. And what happened was they'd make the same decision that the staff involved in that actual scenario did at each stage. Every time I did it, they'd make the same decision. But what I did at each stage, it wasn't about the decision they made, it was about why they made the decision. And people find it really difficult synthesizing all the different bits of information and, if you like, showing they're working. So if an ethics committee is going to do something, I think it's going to help people perhaps make the same decision they were going to have made, but it's going to help them structure the way they think about that decision. So it might not change the decision they made in the majority of cases, but it will help people structure the way they try and make decisions.
I think most ethics committees were the former, but there's two things that I think they find hard to resist the shift towards the latter, which was the decisions made in the pandemic and the policy decisions around then. They were getting drawn into them. I can't see how the patient service user involved doesn't get the outcome of the ethics committee discussion. I can't see how that can happen. It can be denied that. But when that starts to happen, you then get more of a decision-making role. And it's very hard to resist moving over to that. So I think there are two things pulling them towards a broader role, but I think probably most of them are trying to resist that and stay to the advisory, help you think through it way. They may be fighting a losing battle, but I think that's what they're trying to do. I haven't been on many, but that's the impression I get when you hear about forums.
Yeah, okay. So it's funny, I haven't mentioned that at all, but it's taken up most of my time in the last 2 weeks. Question here, wondering about your thoughts on a further role for the ethics committee in ELFT following the recent Panorama programme. Who's watched the Panorama programme? Yeah. People who don't know, this is an undercover reporter who, in response to some whistleblowing allegations, went into the medium secure service in Manchester, the NHS medium secure service, as a support worker, care assistant, and covertly recorded what are pretty shocking examples of abuse of patients at all sorts of levels. And it is shocking. I think the worry when I first heard about it was I was going to watch it and think, I don't feel at all confident that this isn't happening in lots of, I have a job that's also involved in commissioning, and that this isn't happening in some of our units, but it is pretty extreme violence, abuse, boundary breaches. It is interesting. What role would a clinical ethics forum take in that context is tricky, because it isn't usually used as a sort of whistleblowing type forum.
Yeah, I suspect that's part of the worry, and I don't really know. I think there were management structures who were a bit nervous about the ethics committee being introduced in case it becomes this like roving thing that moves across different structures that are designed to stop that happening. So there are structures in our organisation that are designed to stop that happening. Whether you think they're good structures or not, I probably will tell you whether you think an ethics committee should be second guessing. And if you trust those structures, the ethics committee just roving around randomly doesn't feel like the right governance structure. If you don't trust those structures, you're looking for anything that might help. I think that really depends on your viewpoint.
Yeah, it was certainly the case actually in terms of there were certain non-execs and board members and senior people who were very keen on the clinical ethics forum. There were some people who were much more skeptical because I think they were concerned about where this thing sat, who it was accountable to, and where it figured in the whole governance structure. And that, it's reasonable concerns. I'm not saying I know what the answer is to that, or I can reassure them.
it's not resourced to be an inspection regime or a whistleblowing service. So if you're relying on an ethics committee to do those kind of things, you're going to miss a lot. So it clearly, whether if it comes across things, it should raise them, and probably certainly it does, certainly it should if it comes across them. But if you're relying on it to be able to spot these things, it's going to fail on that, because we're saying it's hardly resourced to have a good discussion, let alone inspect and search for things.
Any more questions online in the room? Everyone need an, oh, sorry. Yeah. So I think, let me just repeat that. So I think the question was about if, because we don't currently have a functioning clinical ethics forum, we had a clinical ethics forum, how those discussions, decisions, recommendations could be disseminated and used part of education for everyone, I guess. I think it's a good point. I think that's something we would have to write into any clinical ethics forum that existed, because what you really want to do, and this came up with some of those answers, there's far too many cases like this, so why would we bring every case like this? Well, if one case comes like that, that might be a case that is actually useful to share, because it could become a structure for other people thinking about similar cases, and so we would have to think about that. I don't know how well, apart from Radio 4, clinical ethics forums are being used educationally, and the decisions.
The Bedfordshire Hospital ones, they run a day training session for one of F2s once a year, and that's the ethics committee come and choose a topic or a couple of topics around that. And that's a single example that they do, but they try and integrate themselves into teaching programs. That's different from disseminating knowledge, but I guess it's making people aware that the common issues they face are ethical.
Chloe.
Yeah, I think just further to that point, it strikes me that people who go to an ethics committee, it's going to be a self-selecting group, but it's always the people who aren't going to the ethics committee and aren't asking the questions that you're going to worry more about. So it strikes me that if there is, and I really hope there is to be an ethics committee, because I will be bothering it a lot. But it feels like there would need to be some kind of education role, because actually it's getting that message out there. It's getting people interested. It's getting people recognizing the things that they're dealing with are ethical and legal actually dilemmas. So otherwise it's just going to be a group of people like me and you sitting around talking about ethics and having a great time, but not actually helping the people who are being overlooked.
You may have heard that online because Chloe was at the front, but Chloe was making the point that there's a danger that it will be a self-selecting group of people who use a clinical ethics committee, and what will happen is it will be a group of people, like-minded people, sitting around talking about things and perhaps largely agreeing with each other, which actually is what sort of happened with the ELFT one, because we had quite a nice time every month talking about things, and actually having a bit of time to talk about some quite complex decisions was actually, well, personally, it was quite an interesting and fun thing to do, but that might, by implication, miss some of the more complex decisions that are going on and being taken by people who don't think to use a clinical ethics forum. So.
I mean, I think that's where if you're reactive to individuals who already have got their moral, ethical alarm bells going off, at least exactly that, and then potentially where it goes is when you hear about something and then you can make wide things about, particularly around restrictive practice, about people being in seclusion for prolonged periods. Potentially, you need to go and say, look, we're seeing this happening a lot on your ward. This might be a bigger issue to think about, but then that brings you into that kind of interfering in the governance structures kind of way. And yeah, so the more reactive you are, the more the more proactive you are, the weirder it sits in an organisation.
And so I missed Chloe's end point there, which was emphasising the importance of the educational component in the clinical ethics forum. Matt.
Very used to talk about risk, and I think people find about risk and often risk and ethics. There's a big overlap.
Mm.
We were having to decide about whether it's told niche. And I said that ethics at some point in this discussion was told risk comes before ethics. I always think the same back, but I do wonder that some and maybe part of the reason that work
Yeah.
And these things take time to embed, and especially if they're writing during the time of COVID, it's just about see that people make a really serious big question. It's not that.
Okay, let me try and summarize that. I'm probably not going to manage it as well as you did, but the point was made that about the language, the name Clinical Ethics Forum, and actually there's a big overlap between a lot of things that might be discussed at a Clinical Ethics Forum, a Clinical Ethics Committee, and things that are risky, and the anecdote of being told once that risk comes before ethics. And so I can see how there may be some sympathy for that. And actually thinking about it, I've worked in places that have had high risk forums, or and they've been used quite a lot. And maybe actually they were ethics committees in disguise in lots of cases, which is, I suppose, goes right back to something Paul said at the beginning. There were other ethicsy places where things are being discussed. And but maybe, I mean, you're all going to know now, though, aren't you? So if you suddenly get an email around saying there's a new trust-wide high-risk forum, you're going to go, well, that's the ethics people banging on about ethics.
I mean, it's remarkable that people, as going back to Chloe's slides, it's remarkable that people feel so comfortable talking about risk, given we don't really know what it is, we can't judge it, and it informs all of our practice in the way that we can't predict. It is remarkable that people feel comfortable talking about risk. They do, and they don't feel comfortable talking about ontology.
I've just realised it is 12 minutes to 5, and I think we should stop because it's always good to finish before 5. Thank you very much in the room for putting up with the heat. Thank you very much online for putting up with our incompetence with keeping you engaged and hearing the questions. I hope the last session you could hear everything. Yeah, thank you for answering all the questions, because we will look at that and we'll find a way to make it available so you can look at those answers and see where you fit in the broad spectrum of opinions about ethics. So thank you very much. Oh, yes, good point. Oh, hi. Yeah, no. Yeah, you know, that's right. Yeah, yeah, we haven't met. I say, no, I remember you. Yeah. What was it? Yeah, was it the pen gun? Yeah, yeah. Oh, did you?